Hi everyone, this is Dr. Heather Austin Robillard again, and today's lecture video is going to discuss substance use disorders and commonly abused drugs. Why this lecture video is important is because it could be on the licensing exam for an LCDC. Here are the specific tasks that will be on the test that we will also be covering in this module. We will be discussing the criteria for the evaluation of substance use disorders, different states of intoxication, withdrawal, and psychological and physical effects of certain substances, as well as the commonly used substances and their withdrawal symptoms, and patterns and methods of misuse or abuse of prescribed and OTC over-the-counter medications. So just a reminder, the LCD scope of practice is that we can diagnose substance use disorders. However, an LCDC is not qualified to treat a person with a mental health disorder or provide family counseling to an individual presenting problems that are not related to a substance use disorder. So first, let's check out what is the diagnostic criteria for a substance use disorder. I want to first go to what is an addiction. Now, there are many different philosophies about what an addiction is, but for the pertinence of this class, we're going to primarily focus on how it is diagnosed in the DSM, because that is what is important for a substance abuse evaluation. We use the DSM as a way to communicate the medical model. It focuses on the cause of the substance use, the diagnosis, the prognosis of that substance use, as well as the potential for treatment. Is it a diagnosable substance use disorder is also part of the scope of practice for an LCDC. In your readings, you will find other pertinent information that pertains to assessment of substance use disorders, as well as the specific DSM codes in case you want to practice for your licensing exam or diagnosing individuals. I want to bring your attention to what a medical model typically looks like. There are typically a cluster of symptoms, and then there's a cause, which leads us to assessing. The assessment helps us understand the cause and prognosis. So for example, there is a known cluster of symptoms of a bad cough for 3 weeks, blood, and pain in the chest. Then the prognosis is what course of the disease is. It's possible to be lung damage, kidney damage, or even death. And so what do we know about the treatment of this prognosis? That would be isonized medication. Now look at how we focus this on when it comes to addiction as a chronic disease. We can look at the cause being genetic predisposition. Then we assess, which is what we're going to be learning about in class today, the known clusters of symptoms to diagnose and to communicate can be health-related, obligations. Those are going to be those substance use criteria, which we'll learn about in a few slides. And then also the prognosis. Addiction is a progressive disease and can possibly lead to death. And then what do we know about the treatment? There's maintenance medication, harm reduction, lifestyle changes, treatment, inpatient, outpatient, which again we'll be talking about later on in this semester. So if you already are not familiar with the DSM, it is the Diagnostic and Statistical Manual, and we are currently on number 5. So there were some changes in 2013 from the DSM-4 to the DSM-5. The DSM-4 used to categorize chemical dependency or substance use disorders as abuse or dependence. So it would be alcohol abuse or alcohol dependence. And now they categorize it all together, where you would rate it based off of its severity level. So all of the criteria that are listed here, you would need at least 2 within the last 12 months. Mild severity is 2 to 3 symptoms, moderate severity is 4 to 5 symptoms, and then severe severity is 6 or more symptoms. So let's look at a specific substance use disorder, and this one is the alcohol use disorder. It is a problematic pattern of alcohol use leading to clinically significant impairment of distress as manifested in at least 2 of the following criteria over a 12-month period. Now, this can look very similar among all other substances, which I will give you an example of cannabis use disorder. There is 4 different criteria groupings for the 11 different criterias. So the first one is impaired control. This can be individuals taking larger amounts over a longer period of time, or they're having difficulty regulating their substance use with a desire to quit or cut down. And this is also where craving with an intense desire to use this drug can come from. Then there's social impairment. This is when the alcohol use is impacting their social obligations, work obligations, or other activities within their life. And then we have risky use. This is when they are putting themselves in hazardous or dangerous situations, or have physical and psychological problems, but continuing to use alcohol despite those. And lastly, we have pharmacological groupings. This is where we look at tolerance, which is needing larger amounts of the substance in order to get a similar effect. And then withdrawal, which occurs when they cease taking the substance for a short amount of time and start to have physical and psychological effects from it. Here is another example of another substance use disorder, and this one specifically is cannabis use disorder. Again, we have the same similarities of mild, moderate, and severe, with the same number of symptoms that are needed to diagnose that. As well, you can see that there are similar categories that were listed previously, with just some words changed a little bit. So again, in your readings, I do provide the DSM diagnosis chapter, so you might want to look into that for substance use disorders, just so you are familiar with each substance use disorder. I also want to bring your attention to remission for substance use disorder. In early remission, after all of the full criteria were met, and then when they had a certain amount of time, or at least 3 months, where none of the criteria for cannabis use disorder has been used, with the exception of criterion A4, which is craving or a strong desire to use, that would be early remission. In sustained remission is that, again, after they've met the criteria for this disorder and then they have not participated in any of the criteria for at least 12 months or longer, again with the exception of A4 of craving, because craving is what keeps this as a long-term disease. It's also important that we specify whether this is in a controlled environment or not. For example, if they have gone to jail, they can't use, and so they're not participating in any of these criteria, but that's not the same thing as them being outside of prison or jail and having access to those drugs and not participating in the criteria. In this slide, you can see that there are 3 different types of reviewers. The first row, which is A, is the adolescent chemical use experience continuum, where adolescents might experiment and learning about drugs, or possibly having mood swings. Then they might socially use, again, seeking that mood swing. And then they are operational, where they're preoccupied with that mood swing. And then dependency, where they're having to use in order to feel normal. As you can see, 1 and 2 are in experimental and social, 3 is in abuse, and 4 is in dependency and or addiction. Then B are the types of problems. There is the substance use problem and the substance use disorder. And then C is stages of adolescent addiction. There is early addiction, which is that initiation of drug use. Then there's middle addiction, which is an escalation of use, as well as late addiction, which again is that maintenance or continuance of using in order to feel normal. This can happen through the different stages of addiction, which can look kind of like a tunnel or a tornado. They are participating in intoxication and binging, which leads to preoccupation and anticipation of using the drug, and then they experience withdrawal and negative effect, which kind of brings them back to utilizing the drug through intoxication and binging. The continuance of this cycle or tornado gets bigger until it leads to them experiencing a full-on addiction where craving is no longer a choice. Now let's take a look at the commonly used drugs. First, I want to talk about the different types of administration of drugs. The different ways include oral, intravenous, intramuscular, transdermal, and mucosal, which is like inhalation or possibly rectal. As you can see from this graph, A is intravenous, B is subcutaneous or fat, C is intramuscular, and D is oral or prescribed. You can see how high the peak is, and the concentration is how long it takes to leave the body. Oral administration produces the lowest peak concentration, but retains measurable concentrations for the longest period of time. Whereas intravenous is immediately and fully absorbed, leading to a large peak concentration that is cleared from the plasma relatively quickly. So that's why it's important to understand the different administrations of drug use. This graph just shows you how all of these drugs can impact the body and how they can be administered, which again tells you how quickly it is absorbed into the blood and passes through the brain barrier. It also tells you how quick that peak in concentration is and how long it will take to leave the body. And how does this drug affect? For example, how does heroin IV affect versus snorted cannabis? Now let's take a look at what is the DSM-5 intoxication criteria. So far, we have been taught there are 3 different types of drug categories: stimulants, depressants, and hallucinogens. Stimulants tend to activate the fight or flight mechanisms. For example, meth can increase the heart rate, locomotor, movement, etc., whereas depressants tend to depress the physiological mechanisms and depress that fight or flight response, which leads to slurred speech and a decreased heart rate, just like heroin or alcohol would do. And then hallucinogens is a consciousness and sensory altering properties, which kind of overwhelms the central nervous system. This is an example of hallucinations, which can be had through PCP or mushrooms. In the DSM-5 criteria for intoxication, we would focus on A, which is the recent ingestion of a specific drug, let's say heroin, clinically significant problematic behavior and psychological changes that develop shortly after the ingestion of, for example, heroin. Almost all of the DSM-5 intoxication criteria have these A and B. Then we would also add C. Symptoms are not attributed to any other medical condition and are not better explained by another mental health disorder, including intoxication with another substance. C highlights the importance of consultation and referral, as well as adequate data collection. The next couple slides will show you different charts of the intoxication criteria for some types of drugs. For example, the category of stimulant. You can have stimulant-specific drugs like meth or Adderall or Ritalin. And then I've also given you one that's kind of a common stimulant, which is caffeine. So you can see that the only symptoms that caffeine tend to have are arrhythmias like slower heart rate or higher heart rates. You can also have diuresis or gastrointestinal disturbances, agitation, muscle twitching, or feeling restless and nervous. While other stimulants like meth or anything, you can experience dilation, chest pain, elevated and lower blood pressure, respiratory depression, perspiration, chills, muscle weakness and twitching, seizures, and some may specifically cause hallucinations. The different types of stimulants include caffeine, nicotine, betel nuts, which are natural, ephedra, cat, and then the synthetic or illegal ones like amphetamine, substitute cathinoids like bath salts, ice, which is the smokable methamphetamine, cocaine, which is from the coke plant, as well as crack cocaine. Make sure you've read over the required readings for NIDA's list of commonly used drugs, and you can find more information about the different schedule of classes that each of the drugs are in. Now let's take a look at depressants intoxication criteria. Again, I've listed here alcohol, opiates, inhalants, and sedatives and hypnotics. And you can see that there are different criteria listed for each of these types that show you what it's like for them to be intoxicated. Alcohol, we know, impairs your motor coordination. It can also increase slurred speech or cognitive impairment, whereas opiates can create pupil dilation, drowsiness, possibly hallucinations. Inhalants, those are things like huffing paint, can increase blurred vision, tremors, generalized muscle weakness, euphoria. Sedative and hypnotics can cause problems with rhythmic eye movements, slurred speech, and drowsiness as well. The different types of depressants include alcohol, barbiturates. These are typically medically used for calming and sleep or anesthetics. Minor tranquilizers like anti-anxiety, sleep medication, Valium, Xanax. Other sedatives or hypnotics, those are the non-barbiturates and benzodiazepines like Ambien. Narcotics and opiates, those are to relieve pain or create euphoria. They can be opium, morphine, heroin, codeine, methadone, Oxycontin, all of those different kinds. There are also different street drugs like fentanyl, inhalants such as gasoline, spray paints. So just make sure you're reading over that NIDA list to get a full understanding of those street names and the different informations for means of ingesting and schedule of classes. Then we'll take a look at the category hallucinogens. For here I have PCP and then other. So PCP can cause that rhythmic eye movement, hypertension, numbness, slurred speech, low muscle control or muscle rigidity, and then loudness perception. Whereas other hallucinogens like mushrooms or psilocybin can cause pupil dilation, blurring of vision, hypertension, palpitations of the heart, loudness, and lack of tremors, or lack of coordination and possible tremors. The different types of hallucinogens include naturally occurring ones like peyote, psilocybin, which are mushrooms, nightshade, and then the synthetic or illegal kinds, which are LSD, phencylamine, which is PCP, synthetic designer drugs like MDMA or Molly. Now let's take a look at the cannabis intoxication criteria. Cannabis tends to fall into all three categories: depressants, stimulants, and hallucinogens, because it depends on the type of strand that you can get. But the intoxication criteria can look like redness of the eye, an increased appetite, dry mouth, and tachycardia, which is fast heart rate. Some cannabis strands can create hallucinations. Remember that marijuana is not one drug, it is THC and CBD. Then there's also the different strands. There's sativa and indica. Sativa tends to create alertness, uplifting and euphoric, increased energy, so more of a head high, where indica is more of a body high and it creates deep relaxation, appetite stimulant, as well as a sleep and pain relief. Again, going back to the intoxication criteria, note that synthetic cannabinoids, K2, spice, they are a thing, and it does chemically mimic THC, but it can more likely create a psychotic symptom, cardiovascular symptoms, or even vomiting, paranoia, and aggression. So it's, again, something that can cause a different type of intoxication. Another important category of knowing the different common drug use is their withdrawal symptoms. This will be a hugely important piece when you're evaluating individuals in a substance abuse evaluation, because you will need to make sure that you understand their withdrawal symptoms to determine what needs to happen before they go into like an outpatient treatment or something. So while we can talk about different types of addiction, there is an importance of physical dependence. The removal of the drug from the body can cause an abrupt termination that reveals compensatory effects in the brain as well as the body. This leads to withdrawal symptoms. It is usually the opposite effect of the drug of abuse. So, for example, if the drug intoxication creates happy, it may lead to depression, or if it tends to reduce pain, it may lead to sensitivity of pain when they're withdrawing. This is also noxious. It becomes the barrier for abstinence. A lot of individuals can't handle with the withdrawal effects, and so that's why they start using again in order to reduce the withdrawal effects that they're feeling. As you can see, going back to the slide, there is a lower peak and a longer time in the body, so it's less detectable with withdrawal symptoms. For example, heroin has a half-life to a 1-hour withdrawal symptom. Heroin has a half-life of 1 hour, whereas withdrawal symptoms are 8 to 12 hours. The higher the dose and the more frequent the use, the more severe the withdrawal symptoms can be. Withdrawal goes through several different stages. For example, this is the opiate withdrawal timeline. You start at the timeline with taking your last dose. The first 72 hours is where the physical symptoms are at their peak. Then 1 week, the physical symptoms start to lessen. 2 weeks, the psychological and emotional symptoms are the main concern. And then 1 month is just craving and depression. It is very important to note that physical withdrawal symptoms can be extremely dangerous, which we will discuss in the risk assessment module. There are also psychological withdrawal symptoms that can affect their psychological treatment, which again is why we need to be able to refer mental health issues. Now let's look at specific drug categories and their withdrawal symptoms. Again, if we look at depressants, we have alcohol, opiate, inhalants, and sedative. So there are typically not many inhalant withdrawal symptoms. But with alcohol, they can experience multiple kinds, but the most dangerous one is seizures. Then opiates can have a dysphoric mood, diarrhea, insomnia, fever, chills, hand tremors. Sedatives and hypnotics can also be very dangerous and leading to seizures, which is why we have to have our clients go through detox if their substance of choice is alcohol or sedatives. Here's just an example of those. So the duration of alcohol withdrawals, you can see the different timelines of when those withdrawals start to experience. The serious withdrawals for alcohol can include fever, hypertension, hypothermia, increased pulse, seizures, and tremors. 10% of people experience those withdrawal symptoms. For hydrocodone, you can see that there is a post-acute withdrawal syndrome, or PAWS, which includes sleep disorders, anxiety, irritability, cravings, and exhaustion, which can happen anywhere from 3 to 6 months post their last use of hydrocodone. When it comes to stimulant withdrawal, they can experience fatigue, depressed mood, difficulty concentrating, flu-like symptoms, and headaches. As you can see, there is an example of crack and then crystal meth. The post-acute, which is 3 to 6 months after of using crack, can include anxiety, fatigue, depression, and insomnia, where the post-acute withdrawal symptoms for crystal meth can include anxiety, cravings, depression, and mood swings. Here's also some examples of cocaine and Adderall. The post-acute symptoms can be very similar. However, for Adderall, you'll notice that they have dysphoria and an increased appetite. Now, we may think that cannabis doesn't have any kind of withdrawal, but they can. There can be irritability, nervousness, sleep difficulty, decreased appetite and weight loss, shaking and sweats. Then they can also have post-acute syndrome for up to a year, which includes memory problems, irritability, mild depression, cravings, and a lack of motivation. When it comes to hallucinogen withdrawal, there's not really anything specific, and there is a hallucinogen persisting perception disorder where they experience flashbacks of their hallucinations from using the hallucinogens. But for example, the duration of withdrawal for Molly can be a post-acute of 3 to 6 months where they have memory loss, muscle tension, anxiety, and insomnia. This ends this lecture video today. I hope you learned a lot about the different types of drugs and substance use disorders. Obviously, you will be utilizing this information throughout the course as well as any other courses you're taking for your ADRS minor. So I hope you enjoyed it and learned as much as you can. Thank you.